computer. As I mentioned, lectures are recorded and will be posted on the website and on YouTube for your convenience to watch it anytime you want. Another important message is please join through the Zoom app. I see some individuals trying to join through my Microsoft Teams. Unfortunately, it takes us through a different application, and whoever is trying to join is not going to be allowed to attend that way. Without further delay, I would like to introduce Dr. Kahila. We thank him so much for his willingness to share with us his knowledge in breast pathology. Dr. Kahila is a distinguished assistant professor. Please mute, Dr. Shireen, mute your video and your speaker. Dr. Kahila is an assistant professor of pathology. He practices breast and molecular genetics at Yale New Haven Hospital. Dr. Kahila obtained his medical degree from Ain Shams University in Egypt. He did his research fellowship with Dr. Robert Mutter at the Mayo Clinic in Rochester, where he worked on new strategies to sensitize chemo and radiotherapy-resistant triple-negative breast cancer using DNA repair inhibitors. He did his anatomic and clinical pathology residency at SUNY Downstate Medical Center in New York, followed by a breast pathology fellowship at the Brigham and Women's Hospital in Boston, and a molecular genetics pathology fellowship at the Yale New Haven Hospital. The title of his presentation is Updates on Breast Carcinomas, WHO Classifications, fifth edition. We look forward to his wonderful lecture, and the platform is yours, Dr. Kahila. Welcome.
Thank you, Dr. Tawfiq, for this kind introduction and for the invitation to speak to you today. It's a great honor. I'm going to dive right in. I have no disclosure. So our objective for our today talk, we're going to talk about the diagnostic criteria for different type of breast carcinoma. We're going to understand the rules and the importance of histologic grading, and then understand the rule for special type and the importance of clinical and biomarker correlation in patient management. If you have any question, you can post it in the chat. I will allow time so we can have a good discussion in the end. So the WHO, it includes, in addition to the invasive ductal no special type, which represent 70 to 75% of all breast cancer we encounter, there is 17 other type. Some of them you will encounter your practice, some of them, like until now, I didn't encounter them. Like for example, the mucoepidermoid carcinoma in the breast, the polymorphous adenocarcinoma. I never seen any of them, but all the other I have encountered some of these cases. I want to highlight here that microinvasive carcinoma, its own special type, and tubular, cribriform, and mucinous carcinoma, they are not called invasive tubular or invasive mucinous. Breast cancer is very molecularly diverse. We have some of these rare breast cancer type are fusion driven, like the adenoid cystic carcinoma, the MIP and FIB gene fusion. Secretory carcinoma of the breast, it have the ETV6 intract gene fusion. There is another very rare, newly recognized type, that tall columnar cell carcinoma with reverse polarity, which have a hotspot mutation in IDH2 gene. But really what characterize most of breast carcinomas in general, like IDC and OS, is copy number gain, copy number loss, structural abnormality. This is a research which did chromosomal microarray, comparative genomic hybridization, and it looked at these gains and losses in the different breast carcinoma in a cohort from a 243 breast tumor. It's this study from Sweden and Norway. And you see, each column would represent a chromosome, and the zero here, that is the neutral, there is no gains or losses. And you notice that the well-differentiated tumor will have very simple structural changes, like, losses in the chromosome 8 and 16. But the more you go toward the poorly differentiated tumor, then when you have way more complex structural change. Uh, we don't do that in our practice. That's more for research because these things are not targetable. The targetable alteration in breast cancer are mutation in a single gene like PIK3CA, B10, ACT1, ESR1. Those are there is drug approval for them. You can go to any breast talk and don't no mentioning the gene expression profiling. That's the very historical study. When based on it, now we have the luminal A type, luminal B, and basal type, and RBB2 enriched type. So that's based on the microRNA expression of tumors. So when I teach medical student and resident, I always bring this picture talking about the lobulocentricity in breast tissue. We have this is a terminal duct lobular unit. You have the terminal duct and the lobules opening in it. So anytime we have a lesion, and I always ask them, does it maintain lobulocentricity or there is loss of lobulocentricity? Because invasive breast carcinoma, they don't respect that lobulocentric pattern. So my presentation will be case-based and to get more engagement. So this is a 55-year-old female. She has a right breast mass, 1.2 centimeter with irregular margin. And as you see here, these irregular uh, nest or tubular tumor with desmoplastic stroma, they don't respect any lobulocentricity. If you notice here, this abnormal duct with the lobule in between this tumor, but the rest of the tumor, it's very haphazardly arranged. And if you go on high power to look at this tumor, so you will notice the dysplasia in the stroma, and also you will notice the frequent mitosis on the right side of the screen. Some of them trying to form tubules. So this case represent invasive ductal NOS, and the most important thing we talk about once we make this diagnosis, the histologic grading. And now we use the Nottingham scoring system, which is a modification from the Bloom-Richardson grading system. So this grading system depend on that quantification of the tubule formation, the nuclear polymorphism, and the mitotic count. And if you notice and on the right, that's Ian Ellis, the University of Nottingham, which really made that the grading system more subjective, more objective, and also unified like the mitotic scoring by introducing the diameter of your high power field when you count your mitosis. I want to bring your attention, so we know about the
Para
percentage.
ano ka na eh?
On DMC
Uh,
قاهرة أي حاجة.
Would you mind muting? Okay, thank you. So if you have more than 75% of the tumor forming tubules, and tubules is not just any lumens whose polarization is considered tubules. And we're gonna touch base on that when we talk about the cribriform carcinoma. 10 to 75, that's score 2. Score 3, that's when you have less than 10% of the tumor forming tubules. The nuclear polymorphism and like if you have a nuclei who are very close, like less than 1.5 of the normal nuclei in the background breast, that's when we call score 1. If you start to see like more than 1.5 to twice the normal, and you start to see vesicular chromatin, prominent nucleoli, that's when you give it score 2. Score 3 usually is unique by marked variation in size and shape, but atipia is not necessarily extreme. Breast atipia is not very extreme in general. Why this is important? Because, for example, I get cases when the nuclear score it's based on the entire tumor. So you need to look at your entire tumor and then assign the nuclear score. You're not supposed to go to a small area who have a very ugly nuclei and say, oh, that's a score 3. So the nuclear score is based on all over the tumor. The mitotic count is kind of the opposite. You go to the worst hot mitotically active area and you count your mitosis and you need to find out the diameter of your 40x, the high power field, and you choose like this one, that red dot, that's my microscope. So this is the cutoff I use when I grade breast carcinoma on my cases. So why important the grading? The grading is important because the work done by Ian Ellis and in University of Nottingham, when they looked at very large cohort, the outcome, the probability of survival, and you can see here the low grade have way better survival compared to the intermediate and high grade. So the clinical course of invasive ductal NOS is very heterogeneous. It relates to the nodal status, if it's node positive or negative, tumor size, the grade, as we talked about. Lymphovascular invasion is independent prognostic factor, and you need to see it on the slide. You can't just call LVI is present because the lymph node is positive. You need to document it on the slide because that's how it was studied. The differential we do is, yeah, we need to exclude all the special type. So we do that when we look at the slide. And we need to, it lacks the sufficient feature to qualify for a special type. The rule is not more than 90% of if the tumor have more than 90% from a specific type, it become that type. If less than 90%, you can call it next. So now we're gonna jump to the beginning of the special type. In this case, it was done for calcification. And you see you have dilated duct with some necrosis. And if you look into the cytology here, it's a very polymorphic, variable in size and shape. So this is a case of a DCIS. But outside the duct, you can see a lymphocytic reaction and stromal reaction around some nest of cells who have the same cytologic feature of DCIS. But those are in size is way less than 1 millimeter. We're talking about 10, 15 cells. So this is a microinvasive carcinoma. Microinvasive carcinoma, it's range from single cells to less than 1 millimeter. Sometimes it's very hard to detect, and sometimes we use immunostain to help us with that. Like this is a multiplex immunostain. It's made of P63. It highlights the myoepithelial cells brown. CK514, it's cytoplasmic, and it highlights also the myoepithelial cells. And CK718, it's red, and it highlights all the epithelial cells in your biopsy or excision. So the goal of here, you will see the DCIS, very nice. It had these myoepithelial cells on the periphery and the epithelial cells highlighted by red. But then you look here among the lymphocyte and you find these individual cells who are positive for the keratin CK718. So that it confirm it for you. So what you do next when you encounter these cases? So they always ask you to do biomarker on them. When you go in a deeper levels, I will try to conserve tissue, tell them to conserve tissue. Sometimes the microinvasive focal will disappear on deeper level, but you will try to do the ER and PR and HER2, and also report the ER on the DCIS. And they also, in excision, they want to know the number of foci of microinvasion, how many foci of microinvasion you have. So some data suggests that the nodal because when you make the microinvasion and the patient, if it's younger in age, they may perform a sentinel lymph node biopsy on them. In my institution, we stopped performing sentinel sentinel node biopsies, especially if they are like postmenopausal women, because we found that the chance of finding ITC or micromets or any nodal involvement is less than 5% in our population. But when you go in literature, it's very variable. Another important point, when you're in excision for microinvasion and DCIS, the margin is the same way as the DCIS margin. So you need more than 2 millimeter free margin on microinvasive carcinoma with DCIS or lobular in situ. And we mentioned the quantification of number. Again, for treatment-wise, they don't give chemotherapy for microinvasive carcinoma. We have cases, they go to tumor board and about how many foci of invasion and what is the cutoff to give chemo. It's a gray area. There is no data to tell you, like, is it 6? Is it 12? We don't know. And also, another point that's important, if you think that the microinvasion will get bigger on deeper level, you should do deeper level. There is also a differential diagnosis with microinvasion. When you have DCIS involving sclerosing adenosis, it can mimic microinvasion. So we'll shift gear to the second most common type of breast cancer, invasive lobular carcinoma. She is a 56-year-old female with a red breast mass, and you can see that individual cells in this breast core and some in situ component going on. Here you can see that the TDLU are expanded with these monomorphic epithelial cells. And you can see in adjacent to it, you have these individual infiltrative cells, which characteristic of invasive lobular carcinoma. This is a beautiful high power of view. And also you can see the intracytoplasmic mucin in some of these cells. 80% of invasive lobular carcinoma, they have loss of ecadherin and beta-catenin and apparent expression of B120, but 20% they will have expression of ecadherin, and that will make it a challenge for the diagnosis. And we're going to cover this later on. This is just a bonus case when you have a DCIS in the same duct with LCIS and invasive lobular outside, so they can coexist. Invasive lobular come in so many variants, so they can be polymorphic, like this one. This is the one who they may have, they are poorly differentiated in the grade. They maybe have HER2 positive. They also can come in a variant who mimic histiocyte. We call it histiocytoid variant. You need to be cautious of that because in a lymph node, it will be really hard to detect. Also can be solid variant. Sometimes you don't just get the individual cells line. Sometimes you get solid. This is a case which I encountered. And you can see here in the fat, it really mimic histiocyte. And you may think it's a fat necrosis. But if you do the keratin stain, it will light up all these cells. So this is the histiocytoid variant. Another variant, it's a signet ring. As you see here, all the tumor have the intracytoplasmic mucin pushing the nuclei. And you have the other variant was the alveolar variant. So the variant really, it doesn't dictate prognosis, but it helps you in metastatic setting. Let's say you have a signet ring variant lobular who are metastatic to the stomach. And your colleague get a GI biopsy. They're going to call it diffuse gastric type adenocarcinoma, for sure, if they don't know that that patient have a history of invasive lobular who had signet ring component in it. This is from the WHO, just highlighting the essential criteria for diagnosis, which we spoke about them, and the desirable criteria. The desirable, the coexisting of lobular neoplasia or ecadherin loss. So ecadherin is not mandatory requirement because there is 20% of lobular who retain the ecadherin. And also talk about the prognosis and prediction. So right now, the difference between invasive lobular and invasive ductal, it's all based on the grading. There is no difference between them. So this is the paper I was talking about when they basically took cases who look like lobular and they did the ecadherin and they found ecadherin expression in them. And they were trying to figure out, is it functional or not functional? And in their conclusion of the paper, because they did the other stain and this tumor, most likely, even so in an immunostain, they have ecadherin, it may not be functional ecadherin. And that's why they still have that discohesive individual cell growth pattern. Now we shift to another type of invasive carcinoma. This is a type when you have the lobular component and then you have the ductal component. If you encounter this and none of these components make the more than 90%, then you call it mixed. So you call it mixed ductal and lobular. You don't need to do ecadherin if you are comfortable with the morphology. We covered all this, also lobular. It's known for the multifocality and bilaterality. Usually patients have this diagnosis, they will go and have bilateral MRI to to look for any other lesion. The clinical course, not different from ductal. There is evidence that polymorphic variant and signet ring, if they are more than 10%, they may be associated with poor clinical outcome, but that's not independent of the histologic grade. So the grading is the most important. Why important telling doctor from lobular? It's important because the metastatic pattern. Lobular go to places which ductal usually don't go to, like leptomeninges, peritoneal cervix, endometrial lining, ovary. So there is certain location lobular go, and it's very challenging to detect it there. Sometimes also lobular will do intratumor metastasis when the lobular carcinoma can go to another tumor. So now we're going to talk a very important point that we know that lobular, the low or moderately differentiated, they are by default, they should be ER positive. So there was a problem in Newfoundland and Labrador in Canada when there two patients had ER negative lobular carcinoma, and they got retested and it came back as ER positive. And that result, they went and they retested a 1088 ER negative carcinoma between these 1997 and 2005. And it turned out that 425 patients found to be ER positive. Of those patients, 100 who died without receiving endocrine therapy. That led to a lawsuit, and this because there's so many patients. Endocrine therapy is effective treatment, and there was a settlement and this statute to commemorate this woman who died without getting treatment. And why that important? It's important because, like in my practice, when I make a breast cancer diagnosis, I don't sign the case until I get the ER and BR and HER2. And if there is any discordance, I either re-perform the test, look for my internal control, because the tumor type, it need to match the ER, BR, and HER2. Like a well differentiated or moderate differentiated lobular by default is ER positive. So now we're gonna start going to more rare type of breast cancer. So this mass, she presents with a mass and architecture distortion. You have very low power infiltrative duct in the tumor, but then you also have some individual cells in forming lines in the stroma here. So if you want to call this mixed tumor, mixed ductal and lobular is okay. But this tumor, it have another name called tubulolobular carcinoma, and it's also a tumor who will be like a well differentiated, and it will be by default ER and BR positive too. And then another special type. This one, as you see, it's all forming tubules. You go on high power, you notice the snouts in these tubule, and they have some angulation. And these also have a low to intermediate nuclear score. So this is a case of tubular carcinoma. It's usually an elderly female. By default, they are grade 1, and they are ER positive tumor. And yeah, if you do the molecular expression, they are luminal A tumor. And they have excellent prognosis. So the differential for them will be you need to make them away. They are not well def grade 1 IDC. They are not sclerosing adenosis, radial scar. All these need to be the differential diagnosis. The big differential, I think, the microglandular adenosis, because microglandular adenosis will look like that, and it doesn't have myoepithelial cells. But when you do your ER, BR, and HER2, microglandular adenosis will come back as a triple negative. So that make you like, nope, something is wrong. And most of cases of microglandular adenosis, they get diagnosed in a retrospective way. So this is another case. She's 60-year-old female. She has 2 centimeter breast mass. You see this, a lot of cribriform spaces, so many spaces in this nest of tumor, and there is desmoplastic stroma. You go in high power. Remember when I said the score doesn't just include tubule, it includes any lumens with polarization, like what you see here. There is a lumen with polarization here, so that you should count it. Like here I have like more than 90% of the tumor forming tubular formation. And then the nuclear is like a score 2, and then you need to count your mites in the most mitotically active area. Cribriform carcinoma is this one of the tumor who are well to moderately differentiated and by default are ER, BR positive, HER2 negative. And what's the differential? The differential is DCIS. Can it have the cribriform DCIS, but you're going to do the myoepithelial marker, it will be positive. And another case will also have a cribriform like adenoid cystic carcinoma. It will have that pseudo cribriform pattern. Uh, it's also in the differential, but when you do the myoabs, you will have myoabs outside and inside too. So, and this is a picture showing the myoepithelial, and you always look for your internal control. That is very important. And here it's negative. And as I mentioned, well, deaf, they often mix with other histologic pattern. And we talked about the luminal A, and they have excellent prognosis. Then we jump to another one who have excellent prognosis. This is a tumor, infiltrative, but there is multiple lacks of mucin in this tumor. So you go, and it's very cellular. You go in higher power, you see some lumen formations, lumens with polarization. The nuclei 1 to 2. This is like nuclei 1, like 2. A lot of mucin. So this is make you start to think, and she's more like an elderly female, make you think of a mucinous carcinoma, who are also ER positive, HER2 negative. They come in two variety. They come hypocellular and hypercellular. The previous one was more the hypercellular type, and they can be also positive for neuroendocrine marker. They can have neuroendocrine feature. Neuroendocrine feature on breast, it doesn't make anything. It doesn't like in so many tumor in the breast can have neuroendocrine feature and neuro positive for synaptone chromo, like the hypercellular type of mucinous carcinoma, the solid papillary carcinoma. They can have them. There is another type called the hypocellular. So the hypocellular mucinous carcinoma is challenging in a core needle biopsy because you may get a core which showing lakes of mucin in a stroma, and you may not find any epithelial cells, or you may find one epithelial cells. Then it come in your differential. Is it mucinous carcinoma, or it's like a DCIS with mucin, which the duct ruptured in a stroma? Or is it a mucocele-like lesion, like a cyst with mucin or ADH with mucin? So that is the challenge in these cases if in the biopsy. And sometimes I need to put a differential. In a core needle biopsy, I may not a differential, and I explain my logic why I put that differential. Okay, we talked about all these points. We covered them, the cellular type, type A and type B, the neuroendocrine differentiation, and we said the biomarker. And the differential for sure, any tumor in the breast can have mucin. IDCANOS, no special type, it can have mucin in it. That doesn't make it mucinous. Okay? Because I have seen cases when they come to us, they were called mucinous and they are poorly differentiated, or triple negative, or HER2 positive. Those are not mucinous carcinoma. And why that important to differentiate? Because this is from the NCCN, the National Comprehensive Cancer Network, and which they publish the guidelines in United States to how we should treat patient. So I just got this, and it's a free to download it, and this is the version from April 2025. So favorable histologic type in breast cancer, and they bought the pure tubular, pure mucinous, pure cribriform, and they say that they are ER and or BR positive, HER2 negative. And this is B2, the different T staging. But you see, if they are node negative or node micromet, no chemo. If you go like less than 1 centimeter, consider adjuvant endocrine therapy for risk reduction. From 1 to 2.9, consider adjuvant endocrine therapy. More than 3 centimeter node negative, adjuvant. So they're not gonna consider them for chemotherapy. So that is why it's important to differentiate this tumor and make sure, especially if you're practicing in a place when you don't have the oncotype DX, which basically decide it's a molecular tool which decide which patient will benefit from chemo versus there is no benefit from chemo. Now we're gonna shift gear to more aggressive histologic type, not favorable. This is a invasive tumor, 1.5 centimeter mass. And the tumor here is forming this micropapillary in them, and there is a lot of spaces. But you will tell me, like, is it this a lumen? It looked like a lumen. But This tumor really, this is not lumens, and this is in the three-dimensional, they are spherules. This tumor called the invasive spherule carcinoma, not micropapillary. Because if you do like EMA, epithelial membrane antigen, it's not going to highlight the lumens inside this gland. It will be stained outside. So, and that is the EMA. And see, so if it's a normal lumen or duct, you expect to see the EMA here, but the EMA is here. We call it the inside out, the reverse polarity. The invasive micropapillary carcinoma, also because it's an aggressive type, they are associated with lymphovascular invasion. And in the right, you can see this, the vascular bundle, arteriole, venule, lymphatics, and you see the carcinoma in it. And Rosen have a criteria for LVI in the breast. It should be outside the tumor, not within the tumor, because it have independent prognostic factor. 50% of them can have a positive lymph node, and when they looked at the SEER database, and 20% of them can be HER2 positive. So when I encounter invasive micropapillary carcinoma, even if it's a small component in the tumor, I will repeat my HER2 on that tumor because I may catch a small clone in the tumor who are HER2 positive and it will be behaving badly. So this is summarize what we talked about, the lymph node mets, the HER2, 1/3 of them HER2 positive. They can cluster in luminal A or luminal B. They have poor prognosis. Yeah, important point too, retraction artifact. A lot of my trainee, when they come to me, they will say, "Oh, there is a component of micropapillary." But sometime the collagen will retract around tumor nest and will create like a pseudo pattern. So I always tell them, no, this is not the micropapillary, that's retraction artifact. And another thing, you need to make sure that it's not a metastasis from other organ because micropapillary carcinoma, it happens in the ovary, in the lung, in the urinary bladder too. Another point important in that type of tumor is the HER2 staining. HER2 positive in all breast cancer, complete circumferential, strong membranous. In that tumor, you can get the basolateral pattern, which we always see in the GI and we see in the GYN when we perform HER2 on them. So be careful of that and have a lower threshold to send for FISH testing. So this is a case which I encountered and it had that basolateral pattern, but really I don't have like more than 20% of them with a strong basolateral pattern. So I called it 2+ and I sent it for FISH. And on the left side, on the right side, you can see the interface FISH, the red signal, the small red signal, they represent the HER2, and the green signal represent the CEP17. So this case turned out to be an HER2 negative, group 4. The ratio was 1.18, but the copy number was 4.07, so it's negative. Another case, and it's in the WHO, there is a type of mucinous carcinoma, which they think it's the one who behaved badly. It's the micropapillary variant of mucinous carcinoma. So on the right side, on the left side, you can see this is from our case, which have like, regular cribriform spaces. But here, when you look at the luminal are very irregular. And I want to compare between them. See the lumens with polarization here versus the lumens here. And there is a mitotic figure here on the left side too. So anytime you have a mucinous carcinoma doesn't fit the mucinous carcinoma, you need to know it could be something else. Either, as I said, IDC with just mucin or the micropapillary variant of mucinous. Because I told you the treatment differ. So we did the EMA here, and you can see that is how the EMA is stained in the regular background duct or any duct staining the luminal surface. But in this case, it showed that reverse polarity we talked about. So that make me worried about could it be a micropapillary variant of mucinous carcinoma. This is a study from MSK. It's a small study. It's 5 cases. They did like sequencing on them, and they come to the conclusion that Their molecular alteration is like in between the mucinous and the micropapillary. So, but it's only a small study, 5 cases. Three pure cases were grade 2 and 2 cases were grade 3. Remember when I told you grade 3 poorly deaf, it doesn't go with mucinous to begin with. And this is some picture from the paper. Now we will shift gear to another type. So 44, once you have this circumscribed mass, there is some infiltrated, a lot of lymphocyte on the edge. So you go in high power, you see a lot of syncytial growth. You can tell the cell border of each cell, a lot of mitotic count, as you see, and a lot of lymphocyte. So that tumor, it used to called the medullary carcinoma back in the WHO third edition. Then in the fourth edition, they called it medullary-like. Then in the fifth edition, it was dropped out of the WHO. We don't call medullary carcinoma anymore. So what do you recommend? We call it invasive ductal. We increase TILs, stromal tumor infiltrating lymphocyte. This tumor, triple negative, they're usually associated with patient with the BRCA1 pathogenic germline variant. Comparing to the other triple negative, they have better outcome because the high TILs they have. So don't call any tumor as medullary anymore because medullary doesn't exist. As I said, now it's just IDC NOS with increased TILs. And this tumor, they usually stain with the basal cytokeratin EGFR amplification, and they cluster in the basal-like group. This is another pattern which we receive in consult frequently. You have a very tumor cytologically very ugly, mitotically active, triple negative necrosis. But when the tumor died on the periphery, you can get this pseudo-papillary pattern. So you have a blood vessels and you have tumor around the blood vessels with a lot of poorly differentiated epithelial cells and triple negative. And the question always, is it one of these papillary carcinoma? And the answer always no, because if you look at the papillary carcinoma, like the solid papillary carcinoma, encapsulated papillary carcinoma, those tumors are ER positive tumor, not a poorly differentiated tumor. And now we stage them as a TIS, not even invasive anymore. So this is like a pseudo-papillary pattern. We call it a high-grade IDC NOS. It's just the necrosis causes that pseudo-pattern for you. Now we will jump to a more rare types in the breast. Like this is a 75. She has 6.3 centimeter mass. That's a very large tumor. On the right side, you have these very solid cells, and there is in the left side and more spindly. Here you have nested cells. You need a high power. So we went high power on this is very spindly. If this, it looked to like a sarcoma. It's very spindly, very polymorphic cells. But you go toward the other end where the nests, you found these epithelial cells. So this is a metaplastic carcinoma, a spindle cell high-grade metaplastic carcinoma. We are going now toward the more rare tumor, but remember, this patient had a 6 centimeter mass. When we go more toward that epithelial component, we see this nest with a large granules. They have cytologic atypia, there is mitotic activity. So this is a component, is actinic cell carcinoma of the breast. So the patient happened to have an actinic cell carcinoma, which was one of the salivary-like tumor in the breast, and it differentiated to a spindle cell metaplastic. Spindle cell metaplastic, it's always, anytime you have a spindle cell lesion in the breast, this is your top differential. You need to always, you look for any epithelial component in it, glandular squame to help you. They can be high grade, like the one I show you, but also they can be lower grade cytology. So the differential will be the very broad scar, fibromatosis, myofibroblastoma, fascicular bash, low grade fibromatosis like. And you need to watch out for malignant phylloides, because if the needle go in a malignant phylloides and you only get the stroma, it will look like spindle cell metaplastic. And sometimes we can't tell them apart, and the differential will be malignant spindle cell C node and the node we talk about phylloides and spindle cell metaplastic. And we recommend the excision to figure out, based on the big lesion, is it malignant phylloides or spindle cell metaplastic, because the treatment is different. That's another mass. You have increased cellularity in the core. You go in high power. There is a spindle cell. There is some entrapping fat. There is some lymphoid aggregate on the edge of the core. So anytime you have a spindle cell, you need to throw your keratin on it, and not just one keratin. I'm talking about like a big panel of keratin. And that's what we did. It came as positive for pankeratin and CK5-6, and positive for B63 and for CAM 5.2. But if you go back to the H&E to look at case, it has that long sweeping fascicles and entrapping adipose tissue and entrapping duct. It gives you the feeling of fibromatosis, desmoid fibromatosis. So this is a case who morphologically mimic fibromatosis, but it's picking up keratin. So this is a low-grade fibromatosis-like metaplastic carcinoma. And those are one of the good metaplastic. So this is a beta-catenin, which is normal. In fibromatosis, you will have apparent nuclear expression. It's negative here. Why it's important to recognize this type? Because also if you go to the NCCN guideline, you will notice that certain type, and still the favorable breast cancer, adenoid cystic secretory, low-grade form of metaplastic. And what they are referring to here, they're referring to low-grade adenosquamous and low-grade fibromatosis-like metaplastic, because they have a favorable prognosis without adjuvant therapy. So they're not going to get chemo. But there is rule. It needs to be more than 90% of the tumor on surgical excision. We can make that diagnosis on biopsy. You need the entire excision to evaluate. And they should be HER2 negative. If there is any atypical, if it doesn't fit, then you put it to the invasive ductal NOS, because it changed management. This is the second type. We mentioned there are two types who are metaplastic, but they have a good outcome. The low-grade fibromatosis-like, this is the low-grade adenosquamous. This is a mass-like lesion. There is lymphoid aggregate, and there is a lot of dilated duct or cyst. Then you go on high power on them. This is keratin. You go more, you will find they are infiltrative. Some of them are gland with myoepithelial cells. This is a biphasic tumor, so it have myoepithelial cells around it. But if you do the myoepithelial marker, sometimes they will stain, sometimes will not, sometimes they will have variable staining pattern, because they are malignant myoepithelial cells. They are not benign. And also you can get like squamous nest. So adenosquamous carcinoma, you can have more adeno, more squamous. You can have mix of both, but you need it's a very hard diagnosis to make. They usually arise de novo. They can be associated with benign sclerosing lesion. I said the mixture between the gland and the solid cord with squamous differentiation is it can be low in one, high in one. They always characterized by this stromal, cellular stroma around the tumor nest. And you need to watch for a spindle cell carcinoma. And I'm gonna go back to highlight this stroma. You see this lamellar fibroblast around the duct. This stroma, they shouldn't be positive for keratin. If this stroma positive for keratin, so you should be worried that there is a spindle cell metaplastic hiding in the adenosquamous carcinoma, which is very rare, but can happen. And we talked about the variability in the myoepithelial staining. And we talked about these tumors are locally aggressive, but it have good prognosis. So they just need excision with negative margin. And this is, we talked about it before, why it's important to tell them apart, because the treatment different, if you call these two, low-grade adenosquamous and low-grade fibromatosis-like metaplastic. This is another example. It's also low-grade adenosquamous, but it's more rich on the adeno than the squamous. So you go in high power, they are like, you may think of sclerosing adenosis or something, but they are very infiltrative and haphazard. And if you go in high power, you will see some cytologic atypia, some mitosis, there is some dysplasia. So it's that make you worried. And in certain area, you see squamous will, oh yes, here. you can see squamous areas too, and necrosis in these cells. So that's another case of adenosquamous. And as I say, they have variable expression of myoepithelial markers. So this is scalbonin. So this is one of the tumor in the breast. You will have myoepithelial positive, but still carcinoma. But if you do other markers, like you see here in the calbonin, some of them are weak, some of them are negative. That is expected in this carcinoma. And this carcinoma is by definition is triple negative tumor, ER positive. And as you see here, the internal control is very important on the left side to make sure that your stain worked. There is a paper by Sandra Chen who evaluated this tumor, and it's when it comes to immunostain for myoepithelial cells, they are inconsistent manner, consistently inconsistent. So it's a really nice term when you look at the evaluation of the myoepithelial cells in this tumor. I think this will be my last case because we need to allow time for discussion, and I want to finish by 1 o'clock Eastern time. So this is another case, and you can see there is a lot of solid nest here. You go in high power, you have a very, like a poorly differentiated epithelial cells on here on the left, but the background is more like chondroid background. So this is also another type of metaplastic. It's called like a matrix producing metaplastic. And you can have this like chondroidy component in beside. We are lucky here because we have a very good epithelial component on the right. Sometimes when you give this tumor, because they are a poorly deaf ductal next to them, so they go for neoadjuvant chemo, and sometimes on the excision, what you end up with is the chondroid component. The chondroid component, what's remaining in the excision. I think this is a case of adenoid cystic carcinoma, because I want to allow 5 or 10 minutes for discussion. This is a case of adenoid cystic carcinoma. It's also biphasic tumor, epithelial and myoepithelial. And you can do the stain to highlight the both component. Like this is a B63 highlighting the myoepithelial component. And you see the negative component, you can highlight it by CK7. This is the epithelial component, CD1117. They have the MEP fusion. This is a break apart probe for MEP. And you can see how the two signal here, like the green and red are far. So one copy of the gene is broken, other copy is still fused. So that's adenoid cystic, and we touch base quickly on it. There is always this conversation why adenoid cystic in the breast have a good outcome and indolent, but in other organ not. So this is a study who looked at the difference between them in the microRNA because they are similar in the molecular fusion for morphology, but they found that they are different in the microRNA expression profile. This is the last case in the presentation. This is a case of, as you see, it's have a lot of as microacini, a lot of secretion in these lumens. This is the case of a secretory carcinoma, which also a triple negative tumor, and it have the intrac fusion. They are very rare. This is a DCIS within that tumor, and you can see they are negative for this is the B63 and keratin together, and they are negative for B63. This is S100 is positive in this tumor, mammoglobin. And as I said, they are a triple negative tumor. And look at your internal control in the left side. There is an immunostain for track called band track. So if you have the translocation, it will be positive. And that's just summary of this tumor and how the usually young adolescent female, its differential will be actinic cell carcinoma. It have a favorable outcome. It have the fusion, and this is a good review article for salivary gland tumor in the breast by Dr. Schnitt. He is my mentor. And thank you so much for listening. And I hope we have time. We have 6 minutes for question. Thank you. I went so fast in the end. I apologize.
No, you did very good. Thank you so much for an outstanding lecture and an overview of all these tough cases. some of them are very challenging indeed.
Yes, yeah, a lot of them came in consult service, and it's very educational to me. I learned a lot from them.
And, I'm seeing a lot of thank yous, a lot of claps for an outstanding presentation.
So we don't have any question. Anyone?
Thank you so much, Dr. Mohammed. It was such a great lecture. I have a quick question. For the cribriform type of invasive ductal carcinoma, يعني I find it very challenging to suspect it على biopsy. يعني for me, sometimes this could be just DCIS and case closed. Unless I do my epithelial marker, I'm not gonna get it. هل ده معناه إن أنا any DCIS I should do my epithelial like when it's this cribriform type ولا في something histologically can give me a hint that this could be invasive rather than DCIS?
Excellent question. Excellent question.
Okay.
So when you encounter those cases in the core needle, see if there is any infiltrative pattern of these cribriform spaces, if there is any dysplasia in the stroma. If you are worried about that, do your myoepithelial marker to see if they are negative or if they are negative, you can put a differential. Like usually we call them, for example, if I confirm invasion, invasive ductal with cribriform feature. Because if she have a DCIS, if she has a cribriform, it's gonna need to come out. And on the excision, then you figure out what is it.
Yeah, so it's يعني هو mainly then like my suspicion if there's like dysplasia because يعني I don't do my epithelial on every DCIS
Me
unless it
too.
looks funny.
Yes, me too. I don't do
Yeah.
myopithelial DCIS. That I agree with you. And even some of the DCIS will have reduced myoepithelial expression. So you will have a DCIS, one duct has
Oh.
myoeps, and the duct next to it have less expression or no expression. It's still a DCIS. It just have
Yeah.
reduced expression of myoepithelial cells.
That's
And
even
because
tougher.
there is way more DCIS than cribriform carcinoma, we always need to think of that. There is way more DCIS than cribriform carcinoma.
Yeah, I totally, yeah, sure.
Uh,
Thank you so much.
You're welcome.
One question by Dr. Wala. She wants more lectures and more basic for residents. We're gonna consider it for sure. And another question about the value of P120, confirming lobular versus ductal.
Great. So you don't need to confirm ductal versus lobular. I show you a picture from the WHO. It's non-essential. There is essential criteria and non-essential criteria. The non-essential criteria is loss of ecadherin. And I have told you that there is 20% of invasive lobular carcinoma, they will be positive for ecadherin. So you don't need to confirm it. If morphologically you are confident, you call it. I mean, I know some people still do it, but you need also to, if you do it and it come back as there is something called apparent expression of ecadherin when it's granular or cytoplasmic. So it's not like we use ecadherin and B120 more when we are dealing with in situ, like lobular carcinoma in situ classic type versus DCIS, because the treatment is different. One will go for excision and may not even need excision. So I don't, in my practice, I don't use ecadherin or B120 on cases when I'm suspecting invasive lobular carcinoma.
Super. Thank you again. And we appreciate your effort, appreciate the audience participation and attendance. And with that, we conclude this seminar, and we look forward to see you next month, inshallah. We go and attend the ceremony and enjoy.
Great. It was really nice being here. And thank you so much for the opportunity to talk to you. And if you have any question, you can email me.
Thank you again.
Bye-bye.